Thank you to AbbVie for generously sponsoring this episode of Dermatology Undressed, a provocative podcast. AbbVie had no influence on the selection of the faculty nor content development. This podcast is for educational purposes only and is not medical advice. For personal medical care, please consult a qualified healthcare professional. This is Dermatology Undressed, a provocative podcast. I'm your host, Dr. Lindsay Ackerman, and I'm overjoyed today to bring in Dr. Lindsey Bordone from Columbia University Medical Center in New York. She's an associate professor in the Department of Dermatology and as relevant as anything and exceptionally relevant to today's conversation, she is considered an expert in what we are calling the metabolic revolution in dermatology, how obesity, insulin resistance, and the treatment thereof impact your skin. Thank you so much for being here with us today, Dr. Lindsey Bordone. Please introduce yourself.
Thanks so much for having me. This is amazing. My daughter and I have been watching your show on YouTube, and it's addictive. So it's wonderful that you're doing this, and I'm so excited to be here and talk about metabolic disease and dermatology.
Well, thank you. As I said, I'm just so incredibly excited to have this opportunity to chat with you today. I think we're really going to dive deep. We're going to digest and distill the data. Wow, that was a lot of alliteration early on here. But really to talk about one of the hottest topics in medicine today, and actually becoming one of the hotter topics within dermatology, and that is this metabolic revolution. You were way ahead of your time. You happen to be an expert in this field and understanding how what are still sort of newish molecules for most of us, semaglutide and tirzepatide, what are known in the U.S. as Mounjaro, Ozempic, Wegovy, and Zepbound. And I want to just mention for the listeners, we have no conflict of interest with any of these drugs. But I can understand from the perspective that you have that there is a lot for the public to really, really know about how important these drugs are to metabolic health and moreover our skin health. So I wanted to allow you some time just to introduce this idea of why would these drugs even be relevant to us in dermatology?
So in dermatology, we deal with a lot of different skin conditions that are inflammatory. Like people have heard of psoriasis. You see the commercials for biologics where people are jumping into a lake and they show clear skin because their psoriasis is gone. And we hear about hormonal acne. Some people are very familiar with skin tags, and there's other things about the skin. Even eczema is affected by weight and BMI and metabolic health. And in treating a lot of these conditions, the goal has always been to put people on medications that would decrease their inflammation. And what we've learned through all of this metabolic knowledge that's come out and the changes that we've seen in people on these medications is that actually when we treat a metabolic disease, often we see their inflammation come down a lot. And these conditions that were plaguing them before get much better because we're treating one of the things that's contributing to it. And it plays a huge role in someone's outcome, and it's an exciting time.
Yeah, I couldn't agree with you more. As I've taken a dive into the science behind these drugs, it's become really overwhelmingly evident not how effective they simply are in treating the frank condition of obesity or the frank condition of diabetes, but moreover, how we now understand these primary conditions, obesity and diabetes, to really be inflammatory diseases that are exacerbated by the compounding relevance of weight and insulin resistance. So it is overwhelmingly obvious to you and I, who are dermatologists, many of the skin features that we can identify that tell us someone may have insulin resistance. But, and I'd like to go into some of those for just our public audience to recognize today. But we're really talking about how skin is just an incredible window into what could otherwise be considered hidden internal pathology. So tell me just a little bit before we go into the depths of diabetes and insulin resistance specifically, moreover, how you became interested in becoming a dermatologist. Tell me about you and why this was appealing to you.
I never in a million years thought I was going to be a dermatologist. And I was a biomedical engineer in undergrad. I thought I'd go into orthopedics. And then I went to medical school and I fell in love with the visual aspect of dermatology. I felt like I could walk into a room and know a lot about that patient by just looking over their skin. everything from, and we'll talk about this, like the size of their earlobes and skin tags on their neck and psoriasis on their body. And I had a pretty good idea of what was going on the minute I laid eyes on them. And to me, that was like some superpower where I could assess someone just by a glance. And I fell in love with that and I've never turned back. It's great.
Yeah. You know me and this intelligent angle that I have, and how I am a perpetual proponent of trying to teach patients about these signs that are easy to observe and things that they can keep their eyes on. It's like a very team approach in dermatology. We have a patient that can see everything we can see, if we're willing to talk about it. And so, as we dive into this obesity and insulin resistance, really, unfortunately, pandemic or epidemic that we have going on in the United States and even throughout the world. As sad as that may be, I think there's some new data that you even revealed at the American Academy of Dermatology in, I think, your talk earlier this year about this metabolic revolution, that I think we're hitting the precipice of the obesity epidemic in the United States, and that perhaps we're actually turning the corner and finally, probably by virtue of these medications being widely available, starting to see a decrescendo in that trend where we're actually finally reducing the rate of obesity. Is that true?
Yeah, for the first time since we've been recording obesity rates in the US, as of this, not this past summer, this summer before, I guess we're still in summer. So summer of 2024, that was the first time there was a decrease in obesity rates since they've been tracking it, which is unbelievable. And one of the things that's interesting is we're also seeing some childhood obesity rates come down, and it's not clear why that's happening. And there's more evidence that needs to be gathered, but probably because parental behaviors are changing. So it's a really exciting time. And I think our careers will be marked by a time before these types of drugs and a time after. And I think our approach to diseases is changing much more than we ever thought it would in our training.
Yeah. No, I think you're totally right, and I see that as well. I trained before you trained. I'm a few years ahead of you, and when I look back at where we were when I began my training and where we are today, and just understanding the breadth of complexity behind so many of the inflammatory diseases we treat and the why. Where does this inflammation come from? It's really kind of mind blowing to actually see where we've come in relatively a short period of time. But back to the GLP-1s, and I'm going to call them GLP-1s. Their full name would be GLP-1 receptor agonists, but for ease, GLP-1s, like semaglutide and tirzepatide, which, of course, again, are best known for their treatment of diabetes and weight management. But let's look at them through the lens of skin health and help our audience to understand really how these drugs are changing the way that we manage population health from a dermatology perspective.
So basically, in the past, when we trained, everyone stayed in their lane. If you did cardiac work, you stuck to cardiac work. If you did dermatology, you stuck with cardiology, with dermatology. But what has happened is when patients wind up having diseases in certain parts of their organ systems that are unrelated to the fields that you treat, it does have a trickle down effect. Um, and in not treating those things that are contributing, people just don't get better.
Yeah. It's a lot harder to treat someone who's struggling with a provocative cause, right? And you're just treating more or less what you see as the symptom and not the underlying provocative cause.
And when you think about it, patients would come in and if they had obesity and they were struggling to lose weight and people were just checking their blood sugar and their blood sugar kept coming back totally fine, we never thought about insulin and all the other things that come along with obesity. Like now we know that fat cells produce inflammation. That was not even known before. So we would add medications. You'd add a blood pressure medication because as your insulin goes up, it contributes to high blood pressure. And then a cholesterol medication was added because that high insulin causes your liver to make a skewed sort of cholesterol profile. So then the next thing is your joints would hurt and you would start taking ibuprofen and stop exercising. Then you develop skin disease. So it was like one thing after the next, and you would just add and add it in. And I felt that before I was prescribing these medications, people came in and it was just more bad news. Like who liked going to the doctor? It was like another thing to add onto your diagnosis list. And now that patients are getting so much healthier, you see that really reverse. And I have patients going off of multiple medications. It's remarkable.
Yeah, I couldn't agree with you more. I mean, it's as though our more complicated patients, the patients that were maybe the more difficult to treat psoriasis patient or eczema patient or even hidradenitis suppurativa patient, all chronic inflammatory diseases that when we were sort of turning our head away from what otherwise is a difficult conversation. I mean, there is a lot of stigma that surrounds obesity, and no
Yes.
one, neither you nor I nor the patient in any circumstance wants to be involved in a conversation that doesn't feel good. And when you didn't have a lot that you could do for that component of their, disease entity, the obesity component, it became a very challenging conversation. It's really hard to ask someone to work out when they're significantly overweight, and you know that that's not really feasible in a meaningful way. So giving them, giving patients the ability to sort of shift the angle of their trajectory towards a place where they can feel empowered and successful, and also helps us to manage more complicated disease is kind of this win-win. And
Totally.
I,
Yeah.
I want to go back. I want to go back to you mentioned, that fat cells produce inflammation. There's actually a ton there's actually a ton of information surrounding that, but I think that's something that's not well known in the public forum. Fat cells actually produce inflammation. So a lot of times it's easy for many people to understand the connection between, fat cells and being overweight and maybe having heart disease. But we now know heart disease is an inflammatory disease, right? It's not just because cholesterol was swimming in your blood and got stuck inside your blood vessels. It's actually an inflammatory disease. So without inflammation, none of that cholesterol sticks to the inside of your blood vessels. We now understand in psoriasis and eczema and hidradenitis suppurativa and other disease states that the inflammation that's driving a lot of that persistent perpetual inflammation may in part be actually contributed to by one's central obesity status.
Yeah.
A message from our sponsor. AbbVie's mission is to discover and deliver innovative medicines and solutions that solve serious health issues today and address the medical challenges of tomorrow. We strive to have a remarkable impact on people's lives across several key therapeutic areas. For more information about AbbVie, please visit us at www.abbvie.com.
So beyond these particular conditions of obesity and insulin resistance, you had alluded earlier to the fact that you could walk in a room and from 10 feet away, you already knew a lot about a person by just examining their skin, which is pretty amazing. I think you're right on. I mean, that's what I love most to do and what I love most about our job. The visual aspect of skin interpretation as a sign of internal disease, potentially. But tell me a few of those features that you're talking about so we can be more clear with the public.
So one of the things that is most glaring to me when I walk in a room is when I see someone's earlobes. I don't know if you ever noticed, but sometimes people have these thick earlobes that really sort of puff out and they don't dangle like regular earlobes. Because the insulin that when it gets high causes cell division, you'll have soft tissue growth. So thickened earlobes mirror the soft palate. And as your soft palate grows, that starts to obstruct your breathing when you lay back and fall asleep and relax. So then they develop obstructive sleep apnea. So just by looking at the earlobes and this crease that can develop in the earlobes, you have a pretty good idea if someone has sleep apnea and heart disease.
Wow. Like, isn't that amazing? And something that, it's just intuitive to us when we walk into a room. And yet there are probably hundreds of thousands, if not millions of people that can benefit from just knowing that information. I hope everyone listening goes home and checks their earlobes today. I mean, really, right?
So
Wouldn't
my
that be a
kids
win?
know this. Yes, because I've told them so many times. So we walk around the mall and then my son will say, Mom, that guy's got sleep apnea. I'm like, yeah, you identified one. That's right.
And we know sleep apnea leads to pulmonary hypertension and all sorts of cardiovascular problems. And yes, please, everyone go home and check your earlobes tonight.
Yeah. So earlobes are a big one. And then the other thing that we frequently see is an excessive number of skin tags. Just because of the cell division that insulin causes, you get overgrowth of your skin. So you get skin tags, something called acanthosis nigricans, where areas that tend to have thick skin already have much more thickened skin that looks dark. So on the back of their neck, their armpits, sometimes on the sides of their temples and cheeks, and people come in and think they have dirt on their face, or there's some sort of cream that they should be putting on and they're not sure what it is. And it's just this thickening of their skin from high insulin that no one's ever diagnosed.
And I want to comment on that because this pro cell division influence that insulin really has in multiple body tissues is in fact tied to why diabetics have a higher rate of cancer of multiple different organ types, and something that we just don't talk enough about. But when patients have diabetes and they have high circulating insulin levels, or even in the pre-diabetic state, having high circulating insulin levels, it's just ineffective insulin, you're at risk for cancer. I mean, these are really important features that we can pick up on as dermatologists. Like you say, when we walk in the room, easy features for us to identify. So I want to take it one step further and say that, we're looking at these things as dermatologists, and maybe, our colleagues are prescribing. Some are, some aren't. But let's just say that they're not prescribing and they send a patient to their primary care physician or their endocrinologist to say, look into this, maybe being on a semaglutide or tirzepatide would be, advantageous to you. Isn't this like an incredible thing that then we can be a part of, where we can also actually look at that patient a few months later and almost from just their skin findings changing alone, recognize that perhaps we've actually reversed their cardiovascular pathology in some way, or their sleep apnea problem in some way?
Mm-hmm. And I think to myself, when I see skin tags on the neck, that's like polyps in the colon. Like, you reduce their risk of developing colon cancer, and you could see it right in front of your eyes. Patients see it as well. They're thrilled because you can't see your kidneys or your liver. You don't know that maybe your liver.
And I hope you can't see the inside of your colon.
Yes. You don't even realize that there are all these things going sideways, but you can see your skin. So they're motivated and they see the difference, and it's really exciting for them to get that feedback.
Yeah, no, I agree. I want to pivot for just a quick second, because we're talking about insulin resistance and diabetes, and I recognize that maybe some of our audience kind of doesn't necessarily know how those things tie into one another. So briefly, would you mind just reviewing what type 1 diabetes is? That's something a lot of people have heard of, what type 2 diabetes is. And actually now this new type 3 diabetes, I say new, I think it's being adopted by some specialists a little bit more easily than others, but just give some background to that if you wouldn't mind, Dr. Bordone.
Sure. Well, type 1 diabetes is an autoimmune condition where your own immune system attacks your pancreas and the cells in your pancreas that make insulin to keep your blood sugar within a normal range. And type 1 diabetics generally develop diabetes in their youth, usually after a virus or something that gets their immune system going. And there's a genetic predisposition, and they wind up on insulin because they can't make their own. They have to take insulin in. And type 1 diabetics had very distinct problems that came along with having very high blood sugars. And we know about things like poor vision or problems with ulcers on their foot and kidney disease. What's interesting about type 1 diabetics is because they don't produce a lot of insulin, historically, they didn't suffer from fatty liver. Fatty liver is a disease that occurs with type 2 diabetics, and type 2 diabetics can produce tons of insulin. So that becomes the problem, actually, and the reason why they go undetected for so long. They start off sometimes having a very sugary diet, and that can make them produce a lot of insulin. Also, producing insulin is a stress response. So if you've been very sick or were given prednisone, which makes you produce more insulin, or if it makes your sugar go up and you can produce insulin in response to that, or some other factor that got you producing a lot more insulin than you needed, it's almost like, oh, yes.
Even genetics can play a role in this, right?
Genetics,
there are some people
absolutely.
That genetically just are
absolutely
insulin
in Arizona
producers.
Yes. So Pima Indians in Arizona have the highest rates of insulin resistance in the world because they're survivors.
I think I heard you even comment that, I mean, look at that place. It looks like Mars. So, yes. Right. They're used to like food shortage and having to sustain themselves. And that's right.
Yeah. It's good in the right setting. And this is what I try to explain to patients. If there's a nuclear bomb that goes off and you have an insulin of 60 when you're not eating anything, guess who's going to survive that food scarcity? It will be you. You are a survivor. It's just not good in this setting. So
right. Food is not scarce.
Yes.
Food is not scarce in the United States. Yeah.
Yeah, you can get it in a package and it can stay on a shelf for 3 months, you know? So these patients who just produce a lot of insulin, it's like this analogy is kind of weird, but it's like your mom always screaming at you. You just plug your ears and you stop listening. So then when you're not listening to your insulin, it's not doing what it's supposed to, and it stops bringing your sugars down as much as it should. And then as your sugars go up, your body makes more insulin, and then you listen to it less. And then there's more insulin made. And then eventually you get to the point where you're making buckets of insulin and it's doing nothing. So that's when you run into type 2 diabetes. But you know how long that process takes? Like decades. So before someone becomes supremely insulin resistant and their sugars are just skyrocketing, there's years and years and years where this insulin level is climbing and climbing and climbing. And we see evidence of it in the skin, but their doctor who checks them for diabetes or checks a finger stick says, you're fine. You just need to lose some weight.
It's like the insulin's working just well enough to bring the sugar into normal range, but it's staying at a super, super high level in order to do that. It's like the volume from the mom has to be really, really, really loud for the kid to ultimately, finally, hear them.
Totally.
Oh. And then, there's this, again, new commentary on type 3 diabetes, and I want you to give me a little bit of insight in that and what you think about it.
So type 3 diabetes is what's basically Alzheimer's and dementia as a result of chronically high insulin. And there's different ways that this may be occurring. It might have something to do with the way that you wash away byproducts in your brain. When you have sleep apnea from high insulin and you have poor circulation from high insulin and you have problems with the way that your blood vessels move in your brain from high insulin, then you basically starve your brain of oxygen and you can cause inflammation. You can build up these proteins when you don't have good circulation, washing away the waste that builds up and creates these damaging proteins. So with the 20 years waiting until you're getting diabetes and the time after that when people still had high insulin, and we at one point we were just using more insulin in those patients before we have these drugs. Patients, once a type 2 diabetic was really bad, they were also on insulin they were taking by shots, and we were making it worse. And we still have to use that in some circumstances, but all of that led to dementia, Alzheimer's, and other like vascular diseases in the brain. And there is now abundant evidence that on these medications, you reduce the risk of dementia in such a significant amount that I think the rates of it are really going to plummet in the future.
We are clearly learning about the interface between genetics and environment in this regard. And as the world has changed substantially in 100 years, perhaps the human condition, and that, the world has changed substantially in the past 100 years or so, specifically as it relates to food scarcity, right? We just even a century ago had tremendously broad areas that were incredibly food scarce. And here we are 100 years later, the human condition necessarily hasn't evolved sufficiently to eliminate that genetic propensity for storing calories, right? Being able to produce a lot of insulin to store calories, and yet food is overwhelmingly abundant, not scarce. So I think that what you bring up and bring to the specialty of the metabolic revolution in dermatology is so, so important because, as you just mentioned, the couple of decades or few decades that lead up to this Alzheimer's dementia diagnosis that we sort of are calling this type 3 diabetes phenomenon really could be dramatically mitigated if we're not just waiting for someone to cross the line. It's like the whole runway, right? It's not just about when the plane takes off and the blood sugar is 130. It's what's going on in those 3 decades that precede it. And should we be looking at other things, either with lab testing, or should we as dermatologists be counseling our patients when we see skin hypertrophy, that overgrowth from the cell division that's happening under the influence of insulin, or the hyperpigmentation that's happening under the influence of insulin, or the earlobes, as you mentioned? Maybe we should get your son to be a diagnostician at the mall. He can just point to people that need to go see their endocrinologist or PCP. So this is totally fascinating and stimulating. I want to circle a little bit back to the specific chronic inflammatory diseases within dermatology and how you see the role of these agents in helping us treat psoriasis, eczema, and maybe hidradenitis suppurativa, or any other thing you want to bring into the conversation for sure. And then I want to pivot, and we're going to go elsewhere.
So the interesting thing with dermatology is we have evidence that if I'll use psoriasis as an example because we have so much evidence that psoriasis is affected by weight. Also, hidradenitis suppurativa, that's behind psoriasis in terms of catching up with the publications. But psoriasis, if you have a BMI of over 35, your response to the medications for psoriasis takes a nosedive. I mean, patients fail these drugs left and right. And we always knew that patients who were overweight tended to do worse. But with big data, we learned exactly how bad it was. And that's because as your fat cells grow, they stop, they start producing what's called interleukin 6, and they also can produce interleukin 9 and TNF alpha. These are just inflammatory markers that float around in your blood and they make your psoriasis worse. And then that inflammation also makes you more insulin resistant. And I've mentioned this before,
It's
where if you have joint pain from psoriasis and your skin is covered in plaques, you're not going to want to go to a gym on your, uncomfortable joints and get on that treadmill. And you can't even sweat efficiently if you're covered in psoriasis plaques. It's a very uncomfortable position. So it starts to snowball.
And let's be real, for people that are going to a gym, they're oftentimes in gym clothes, and having, flakes of their body falling off on the equipment is, fairly embarrassing. I mean, I've had a lot of
People look at
patients
that. Yeah.
cry to me and say, the last time I went to the gym, I could tell that the two people next to me on either side on the treadmill were looking at me with like, what's wrong? Am I going to catch that?
Yeah.
So there's also a component of us not adequately having yet treated their disease. And it's hard to go to the gym and,
Oh, yeah. And I had a
reveal your.
patient actually, he had so much joint pain from psoriatic arthritis. And I said, well, would you be able to do some water aerobics or something that's easy on your joints? He went to a pool and the lifeguard said he couldn't go swimming without a doctor's note because they thought he had a communicable disease.
Right. This is the reality of what our patients with these chronic inflammatory diseases are living with.
Yeah.
And when you've had experience in treating these patients with, semaglutide, tirzepatide, in addition to managing their primary inflammatory disease, what's been your experience with that?
Excellent. I mean, it's not an instant change. You have to take the long road of slowly losing weight to lower the BMI, but even just reducing the insulin, generally they start to improve pretty quickly. But that happens much earlier than the weight loss. Within a week, people start to notice improvement, and the studies have shown there's improvement in the insulin levels. So with proper counseling and then using it as a tool, I mean, the difference is just mind blowing. And the other thing that happens is patients are not able to tolerate as much alcohol. So for patients, and they don't want as much alcohol. So for my patients who used to be heavier drinkers, their alcohol intake goes down pretty dramatically. And that also, we know, has a huge impact on psoriasis. So that contributes to the improvement as well.
Yeah, I'm glad you brought up the alcohol piece. It's actually not, necessarily a focus of this podcast, but it's an enormously important factor in how our psoriasis patients actually can respond to therapy. You're 100% right. So we've talked a lot about medical derm, how skin is this incredible window into internal hidden pathology with regard to inflammation, how assessing one's, visual appearance, so to speak, from, when we walk in the room and being able to hone in then on a really meaningful conversation where we're saving people comorbid ailments down the road is really impressive and important. But I want to shift gears a little bit and actually talk about some of the aesthetic concerns or benefits, for that matter, of these GLP-1s. So there's clearly a lot of chatter about, Ozempic face, where this rapid weight loss can basically change the appearance of the skin from an anatomy perspective, right? Where, contours and so forth might actually look less favorable rather than more favorable. And then there are actual biological changes that happen in the skin. And some of them are somewhat controversial, whether GLP-1s are helpful as an anti-aging tool or maybe even a little bit hurtful. So I'd love to hear your take on that.
So I think that with any rapid weight loss, like if you've ever seen a patient who's gotten out of the hospital or has had a really bad flu or some extended version of COVID, if they have rapid, profound weight loss, they look gaunt. And I think with these medications, if patients aren't dosed appropriately, which we saw in many cases when the drugs first came out and they were becoming so widely available on the internet through these websites that really were not monitoring or counseling patients. people would have this very rapid weight loss, and any rapid weight loss can cause what people deem like Ozempic face. So I don't think it's actually the drug. I think it's the speed at which people lost weight and things like dehydration. But now that more people have become attuned to the best prescribing practices and patients are very aware and they're on Reddit, they know that if they lose weight more slowly, they'll have a better outcome. And again, I think this is something to use as a tool. I think if you lose weight slowly and you exercise with it, you don't get this sagging skin. I think if people use it and lose weight rapidly and they just don't eat because they're not hungry and they are excited because they've had a hard time losing weight their whole life and they really want to go for it, like you have to remind them, okay, we got to do this slowly, because otherwise they wind up having a lot of hair shedding and they have a change in their facial appearance. And those are things that obviously can get better if you slow it down and eat a little bit more. But yeah, I think it's more a side effect of the weight loss rather than the actual drug.
Yeah, I mean, and you bring up a couple of good points in that conversation, Dr. Bordone, specifically the monitoring, right? These drugs are, frankly, they can be challenging to get with prior authorizations and so forth, but they're done under the appropriate circumstances of physician supervision or an adequate, healthcare provider supervising in a team that's probably led by a physician, versus trying to get to somebody online potentially who you may or may not have ever met in person, and you're signing up for some subscription service and getting a compounded agent, which may or may not be exactly what you think it is. And there is risk for weight loss to be happening too quickly and subsequent, again, problems that arise from that, like you mentioned, hair loss, nail fragility, people actually getting ill and dehydrated, other downstream effects that are obviously suboptimal. So let's look forward. I guess I would just ask, what do you think is the most exciting future development in this realm of GLP-1s and the ability for us to change inflammatory diseases across multiple organ systems? Again, I consider you a real expert in understanding these agents. And while we're here to talk about dermatology and the impact of these GLP-1s in dermatology specifically, I'd love for you just to talk about what you think is really the most exciting aspect of them moving forward.
I cannot tell you how excited I am for the future. I think for so many years, we thought of this cascade of things that just happens to people. Like when you get older, you gain some weight, your blood pressure goes up, you become pre-diabetic, your cholesterol becomes abnormal. And I think that was just the way things, went in everyone's medical life. And now it's different. And we have some tools that actually control how high your insulin can go. And we can detect when you're falling into a metabolic problem. And we can use these tools to also help your inflammatory conditions. And I think many people in this country who have chronic inflammation, it's because they've developed adiposity, which is obesity. These adipose tissues, fat cells, have grown so large and they're producing so much inflammation, and they have such a poor quality of life as a result of that. So I think instead of going to a doctor and getting bad news and another diagnosis, people are actually going to get better help, and they're going to shed some diagnoses, and they're going to be very motivated to live a healthy life. So I think we're going to continue to see this health trend where people feel good, they age better, and we have more elderly people that are living independently and don't have problems with memory and dementia. And we have parents that are not tired and they can go and play with their kids because their joints don't hurt and their psoriasis is clear. So I think in so many ways, the future is just so bright. And actually, selfishly, I think our jobs as physicians are becoming much more positive. Like I have patients that skip in skinny jeans and they're like, look at me, they feel so good. And I help them get there. So it's such a great interaction. And I just love it. I mean, I've never had these situations before where people are excited to come back and show off their progress and they feel so good about themselves. And it's great.
There's no better interaction than when you walk in the room and the patient stands up and they're smiling ear to ear and they want to like lean in and give you a big hug. It's the best. And, we are living through what I would consider a real revolution. I'm going to take it one step further and ask you, would you actually go so far as to say that you think dermatology specifically, by looking at skin findings, are going to be basically at the helm of detecting what we would consider otherwise biomarkers
Oh,
for
yes.
someone who's, needs a drug like a GLP-1.
Undoubtedly, because what happens is people that are in their 20s, 30s, and 40s, they don't have real health problems like cardiac disease. They don't get stents. They go to a dermatologist because they see something on their skin and they're worried about something on their skin. They don't see that their kidneys are pickled. They see that there is some inflammation on their skin and they go to a dermatologist. And I think dermatologists, even more than primary care, are going to play a bigger role in identifying this and, if not prescribing it, directing the patient in the right direction so that they get on the right road and have the treatment that's going to help them have a longer health span.
It's awesome. So for our patients that are listening, our potential patients, for the public that is listening, tell me one thing that you want them to go home and look for, or a few things that you think are really key that they should go home and look for in either themselves or someone that they love that they're maybe concerned could be experiencing insulin resistance.
I always look at earlobes. I can't stop myself. Whenever I'm anywhere, I look at earlobes and I think sleep apnea, heart disease. So if you have very thick earlobes that look like a cute little baby and they're pudgy, and you've had a hard time controlling your weight and you're overweight and you feel tired frequently, definitely bring that up with your doctor. The other thing is skin tags, just growth of skin tags in the armpits and the groin, and excessive skin tags at a young age. That is a huge sign. And then for women, I always say, if you have a regular period and you're getting hormonal acne on the lower face, or you're getting any cystic acne in your armpits or your groin or under your breasts, as with hidradenitis suppurativa, really that is a hormonal issue. But many times those hormones are just not functioning. Things aren't functioning normally because of obesity or insulin resistance. So don't give up and assume it's just acne and the acne meds aren't working well. Look into metabolic causes. So because there's so much help and things can be so much better.
Yeah. And I think one thing to just leave our audience with is, recognizing that there's such an interplay again between genetics and the environment. And there should be a destigmatized relationship that you share with your doctor. This is not anybody's fault. In fact, this is really the team-based approach that's best, where we can come in and serve as sort of a sentinel in recognizing features in the skin that may be telling us a deeper story, and use that as a way to partner with the patient, not just in identifying what that skin feature is and fixing it, but letting it tell us how we're going to help that patient live not just a longer, but more well life.
Yes.
For the rest of their life. Thank you so much, Dr. Bordone, for your expertise and, moreover, for making yourself available for this public forum today.
I appreciate you. Thank you for doing the show. It's wonderful.
And thank you all so much for listening on what I hope you found to be an enlightening topic, the metabolic revolution and your skin. If you've enjoyed this podcast, please share it with those you care about, and don't forget to subscribe. Until next time, stay kind and stay curious. This is Dermatology Undressed.